It's with great pleasure today that I introduce my friend and colleague, Dr. Gorbis. Dr. Gorbis has been on the faculty at UCLA for many years and now at Keck School of Medicine. And she is the director of the Westwood Institute for Anxiety Disorders, which is a very innovative and renowned program, very holistic program to treat the most severe of anxiety disorders. And if you look at her CV, she has lectured all over the world, invited presentations on the treatment of body dysmorphic disorder, obsessive compulsive disorder, anxiety disorders, and treats really the most serious patients, and a very, very difficult job. And today she's going to tell us about a condition which I didn't realize was as prevalent as it is, and very important for our patients, postpartum OCD. Thank you.
Good morning, ladies and gentlemen. Good morning, my dear colleagues. First and most importantly, I'd like to thank Dr. Rapkin. It is a great honor to be invited here to talk about OCD and postpartum obsessive compulsive disorder, since it is extremely important subject in terms of dissemination, the knowledge about this treacherous and difficult disorder. Besides that, I also wanted to bring up and talk about gratitude, my eternal gratitude to Dr. Rapkin for being my doctor and timely diagnosing me 4 years ago and taking me out of grave and all the way to the grand rounds, because she had the presence of mind and ability to sense that I had an illness, sent me for the assessment and diagnosis, was absolutely right when there was no need to do these tests, and here I am in front of you, presenting at grand rounds. And there are no words, Dr. Rapkin, for doing so and for actually taking me from grave to grand rounds. I thank you very, very much. So I'm going to talk about obsessive compulsive disorder. What it is, a little bit about what it is not. Obsessive compulsive disorder, as it relates to postpartum and prenatal disorders, as well as talk about its relationship and hormonal play, the role of hormones in onset of OCD, and also how to diagnose, which is the most important. Diagnosis is most important in any medical field, because for doctors, it is not really as important, the later on stages, but it can be a matter of life and death, as it was in my situation, but also a matter of quality of life in chronic illnesses. OCD is a neurological disorder. It's a medical condition, and it is characterized by intrusive thoughts, images, and impulses that enter one's mind against one's will and cause significant level of distress. Distress is the hallmark of obsessive compulsive disorder. These thoughts are intrusive, bizarre, and inappropriate. They are not simply thoughts of worry, everyday worrying. like, what's going to happen with my health, what's going to happen with, my ability to take care of this baby, am I a good enough mother? These are intrusive, horrific, horrible thoughts. It sometimes is, oh my God, I'm going to drop this baby, and then the pictures evolve, he is in pool of blood, my husband is entering the room, and everybody sees that we need to rush him now to emergency room. Instantly, they find out that he's a brain damage, it's an ongoing disease for the entire life, and I'm guilty, I am not a fit mother, and so on and so forth. These thoughts are resulting because of the distress. And remember, in obsessive compulsive disorder, thoughts are equating to the action, unlike in anything else. In our minds, which is 98%, almost 98% of human population, we know there is a difference of a thought and the action. Like me thinking a thought, and very often, we have transient horrific thoughts, but we're able to distinguish between the thought and an action. In OCD case, nobody can. They are merged, like with crazy glue, to these thoughts. They see it as actually and experience it as an action. Compulsions are there because it is experienced in such a disastrous way. And they can be overt or covert. There be repetitive behaviors, mental acts, and rituals. Like, for example, they can be undoing the harm by having a blank slate, like a clean slate in their mind, or washing their hands actually in reality. And I've seen cases sometimes when they have no longer any skin, or the mother constantly cleaning and washing repeatedly the baby because she feels that he is unclean. I recently, 2 days ago, talked to the woman who takes care of the babies. I don't remember what they're called already. And she said, I recently had a woman who made me wash constantly. I was the sixth nanny in the household, and she said because she felt that I didn't smell right, she was sending me to take the showers, and then I recalled her relationship with you that sometimes it's true. She had an icky smell that because the five senses are exaggerated because of the basal ganglia that is connected to the gut reaction in OCD once it's triggered to protect the baby. She was smelling, something. So, obsessions and compulsions cause emotional distress, must be there. It's not, obsessions are not accounting crime for sure, ladies and gentlemen. They're not. Neither they are a word that is commonly used and overused in literature, in poetry, and even in everyday life. Oh, I'm obsessed with this man. Oh, I have an obsession with this woman, it's overly used. It's not that. It's 24/7 like a crazy glue. It's there all the time, and there is nothing more treacherous than that. In Latin, if you translate, obsession means besieged, possessed. And fortunately enough, we don't live in Middle Ages because in France, these people were burned on stake. And in England, it was easier, they were hanged. Or whichever one was easier, I don't know. It was not, it was considered refractory until 1966, until Victor Mayer, an American psychologist, came in. Up until then, was considered refractory, and people with OCD were confined to mental institutions. Compulsions can be separated overall in three different things. Dirt, germs, bodily waste, and chemicals. Like, you know, I touched this certain chemical and now it's spreading all around. If I touch this and there was a chemical on it, now I touch someone else. It's person, time, and place spreading. Okay? Or if I touch the baby that was unclean because this woman with this smell touched him, now everything in the room is already unclean. So she begins to wash everything in the room, you know, besides sending the woman through the shower. So obviously there is disturbance in the functioning. There are mistakes. The hallmark of OCD is the doubt. La maladie du doute, it's called in French. It's called the disease of the doubt, they call it. And so the doubting is not about, like, should I marry this man or should I buy this house? It's about anything and everything, the vacillation, going back and forth. It's about, should I buy bread that is gray, or should I buy the loaf of bread that is white? Should I go to City National Bank or Wells Fargo to cash the check? This type of thing about everything in life. Impulses, they're related to violent, sexual, and religious obsessions. Oh my God, I touched the genitals of my baby and I am a molester. Oh my God, I touched this knife and now I see that I have pushed this knife through the soft part of the head of my baby. And it's happening repeatedly. Okay? I had a case where a woman was repeatedly sitting in front of a fireplace 20 years ago, maybe more, and throwing the baby into the fireplace, and the little blanket was staying on her lap, and her husband was yelling at her, "What did you just do?" And she always shaked. I mean, as we got her to us from another state, she was like shaking all the time. No touching. Because she had these images, right? 24/7. And then order, neatness, organizing, symmetry and exactness. Usually for us professionals is very important to know there is a Tourette syndrome that is there in these cases as well. Okay, compulsions are there to prevent harm, to reduce discomfort, done automatically without awareness, and very often we get the cases where there is no awareness. They're very dangerous because there is no insight, and can be related or unrelated to the obsession. This is the OCD cycle. So she gets an obsession that this woman that is a nanny smells bad, she's dirty, sense raises anxiety that everything is dirty about this woman. She touched the baby, she touched the sheets, she touched the cradle, she touched this and that. And compulsion is go and wash yourself. That's the first thing. She comes back, she says, okay, you can stay with the baby. Then she walks around the cradle. This woman was expecting. She almost walked around the cradle like this in circles, and 10 times, 20 times, whatever her compulsion told her to do until it felt right. The problem is that it's snowballs. It's never enough. And then there is a relief, and then the obsession starts anew. This woman is dirty. This baby cannot be touched. Finally, after a certain period of time, she was fired. at the home. And the husband paid her and whispered at the door. She said, "You're not the first one. There were many that didn't survive this. Yeah, I'm very sorry." This is how the picture of OCD looks when there is a prenatal or postpartum OCD, and it can lead to not ever bonding with the baby, not ever touching the baby, and the worst, also the baby, in difficult cases, and I talked to this mother, being taken away from the mother by Child Protective Services. I'll talk about it a little bit later. Obsession versus worries, right? Generalized anxiety disorder, when it is generalized anxiety disorder attached to it. The differential diagnosis is, I worry I'm not a good enough mother, there is a lot of stress, I cannot really take care of this baby, too much responsibility. Oh my God, I'm worried, my pediatrician is not really good. He was very brief when I came to, for a checkup, and he is rushed, and or oh my God, my baby, he said that he's 200 grams, a little bit less than he should be. His weight, his length is a little less. And he told me that to change the formula, but what about if this formula is not right? But it's related to real life events. Okay. Now, person with OCD will you're not allowed to get into the next to cradle, next to the child's room. Nobody is allowed there, not even father, not even anybody. Okay, and then maybe even she thinks that she is also contaminated, and then she avoids the baby altogether. We've heard of such cases as well. That's the OCD, and there is a danger there. And obsessions are not related to real life events. They're bizarre. And they're there 24/7. People who have generalized anxiety disorder, they're lighter and they're usually functional, unless generalized anxiety disorder, and we've seen that. What are compulsions versus impulse control? Compulsions are always ego dystonic. Dystonic. Ego are alien, not pleasurable. They're warding off anxiety, and they're causing a lot of guilt, remorse, and they're endless. Such as washing hands, such as checking, calling for reassurance, on and on, checking on the computer for all kinds of diseases, thinking, maybe I have this, and they're sitting for 12 hours, they're doing nothing else, nothing else. Well, 14, I had a patient with BDD, and that's a cousin of OCD as well, who missed her 36th birthday by some 30 hours because she was doing her lashes. And when so I called this case Lost in Lashes. She arrived to the party 30-some hours later. And it's true, it's true. It's like not a dream that I'm telling you. Because they are completely lost in time and place, and they're completely bad. But that's a difficult subject, different subject, different action. But they lose time on computer checking, this doctor, that doctor. In these cases, it would be this pediatrician says this, chatting with the mothers, and in the meantime, the time passes and the baby is neglected. Okay, but they are always either dystonic impulses, either syntonic, such as over sexual activities. During the activity, there is a lot of pleasure, and there is excitation before. In planning, I'll do that, and this is somewhere there, excitation, and then release of this tension, pressure. During the eating binges, they're experiencing pleasure, and tomorrow morning, oh my God, I'm 2 pounds more. But they devoured already the jar of cookies, or they will drive to get these cookies because, but in between, in cases of bulimia, they constrict or they eat perfectly normal, right? And then also in the cases of gambling, and I actually remember this case, my husband and I were in Las Vegas one day, and I'm passing through and I see one of our friends. And I called his name 3, 4, 5 times. And he's gambling. He didn't even respond. Once he raised his eyes and they were blank. And I'm like calling his name loud, even because it's very loud there. He didn't recognize me, and he was like enchanted, in this game. He continued to gamble, and then when we got back with my husband, he says to me, very sadly, because he was a friend, he lost everything. He hitchhiked to Los Angeles, and he lost his house. His wife is divorcing him, and he lost his supermarket to the gambling. He was a good guy, very well known. So that was the end of this particular situation. So in any case, again, they don't. They are so much into the game that they don't. They are enjoying it, but the remorse, guilt, and the losses come later on. This is not how it is with compulsions. Epidemiology, 1.3%. OCD has a live prevalence around the world and multiculturally 2.5%, which is equivalent to 6 million Americans all around the world, despite of socioeconomic classes. Onset of OCD, we exactly don't know. It is a neurological disorder. Risk factors are genetics and biological, environmental stressors, and hormonal imbalances. I should put like this in big letters. First degree relatives, 25%. Like if there is 4 sons in a family, one will have it. More prevalent with monozygotic twins, 63% years apart, one mother Chinese, another Russian, that are real apart, same, exact same, they have both OCD. And in fraternal twins, 50%. Still, it's not 100%, we cannot claim that it's purely biological. Abnormalities in neuroimaging studies show frontal lobe abnormalities. They show which frontal lobe we all know that is involved in what? In planning, organizational skills. I mean, those who cannot organize, there are problems there. So it affects that. And basal ganglia involves also routine activities and routine behaviors. Like for example, when they get up in the morning, they may go first to the shower, then to the bathroom. Then from the bathroom, they feel very dirty, and then they go to the shower, and then they feel incomplete in the shower, then they need to finish the bathroom, and then the cycle is endless, so they end up doing the routine activities of the morning for 4, 5, 6 hours. Dr. Sadia, is it correct?
Yes.
Singulatum. It's fibrosis bands that assist the communications between the brain and behavioral and emotional messages. It's kind of, they get stuck. We say they get stuck in a gear. They are way, way normal in their intellect. They're fascinating people, and a lot of them are with very high degrees. Many doctors at Jane and I treated who have educations from UCLA, from Harvard. Many have multiple educations, and it's fascinating to talk to them, but we must be careful because they never want to do anything. They're non-functional, like in terms of doing things, but their compulsion is talking, which is very difficult to get rid of. and Dr. Kagan, who was the chief of staff at UCLA, he used to tell me, maybe we should put this plastic over their mouth, and then Dr. Gorbis will be okay. And so the stressors, any stressor, even getting married, moving, all kinds of stressors, getting sick, and getting adjusted to their sickness, any stressor will get OCD exacerbated. There is a serotonin hypothesis, abnormally low in OCs, and it impact anxiety. When there is a low serotonin, they impact anxiety. That's why I guess, and Dr. Sajay maybe will second me on that, serotonin reuptake inhibitors really, really help, but they help at the max doses. Over 12 weeks, whereas in depression, it's only 6 weeks at much lower doses. Now, autoimmune response to streptococcal infection in 2004 was found to be a great deal of a problem. The onset is usually overnight, and mothers describe it like I put one kind of a child to bed and a different child woke up. It's very stressful, very much overnight, and they really appear, these children appear crazy, like running around totally naked, not wanting to put any clothes on, and really like having this quote-unquote crazy thought. Environmental stressors are abuse. If PTSD starts very, very early in life, then obviously the child very often has comorbidity or onset of OCD, difficult to treat. Physical changes and occupational changes. I already mentioned all of this. Hormones. Every medical doctors, what are the hormones in medicine, in terms of what role they play? All right. I see your bright eyes, and I know that you know. They are what? They are a conductor for all the organs. Everybody else plays what? What the hormones are basically telling them to do. Okay? So I don't know if you disagree with me. I put it in this terms. Studies show that people with OCD have abnormal hormones levels, and that hormones may play a role in triggering OCD. Very, very evident in when there is a transition to adolescence in boys and girls. When there is a premenstrual period, if I count the days, and I exactly know when there is going to be exactly such. How many times did you work with, when we worked together, did you address this issue medically? Frequently. It's very, they really are very sensitive people. And they react to that very, in a very way. So then it is also known that estrogen level, when their estrogen levels are the highest, and estrogen levels can cause anxiety. We also know that they actually elevate anxiety levels, and there is. When the hormones are the highest, symptoms during pregnancy, in 30% of the women, the OCD is observed, and definitely the exacerbation during this period of time, especially the last trimester, we must watch out if there was a OCD that was there before, and also I will be talking about the OCD that is triggered during last trimester and postpartum. Other hormones factors. Pineal hormone, melatonin, with our multidisciplinary team at our institute, which includes medical doctors, which includes neurologists, which includes also doctors, endocrinologists. We just have an appointment, we missed one appointment for one very, very important, all the cases in which are complicated, therefore we need to be working with people that are outside of our expertise. And so endocrinologists are often part of our treatment, right, Dr. Tim? And Dr. Kronemeyer is here also. So melatonin induces sleep and is deficient in OCD. In people who have OCD, this is why the first thing that we do is sleep-wake cycle. When it's messed up, they usually don't sleep at night and sleep during the day. So we must reverse it. This is the first thing that we do, is reversal. But it's easier said than done, obviously. But usually we try to do it within the first week, but then they mess it up again and again and again and again, because the automatic need is to go back to the patterns. Stress hormone cortisol is released in response to stressful conditions, and it's shown to be elevated in patients who have OCD and definitely PTSD as well, and other anxiety disorders. Very, very high. Now, estrogen known to promote anxiety among OCD is being implicated increase in androgenic activity, and progesterone evens it out. Postpartum period, dramatic drops in both estrogen and progesterone. As soon as the baby is born, all of this is gone, out, emptied out, as soon as there is this grandiose separation and the baby is out and the umbilical cord is cut. Elevated levels of oxytocin, thank God about that, and increased activity in hypothalamic pituitary adrenal. Pregnancy can lead to onset of OCD. Out of 76 women, 32.1 onset of in perinatal period, and 15.4% postpartum. Exacerbation out of 132 women in 34, exacerbation of the symptoms. U.S. Birth rate in 18 was 3,788,000 to 235 million women gave birth, and out of them, 85,000 of all these women had an onset of OCD. Each year, during the postpartum period, at least 300 had met likely the criteria for obsessive compulsive disorder. Pregnancy postpartum onset of OCD 1.7 to 4%, and exacerbation of OCD between 25 to 40%. Reoccurrence. Because OCD cannot be cured like cancer, can be dormant, stable, you can be cold stable for many, many years, but it's there, dormant, like a volcano, okay? But there is nothing in medicine can be killed. So, and then it exacerbates if they're under stress, under, illnesses, and definitely during prenatal, postpartum, and it's like eruption of the volcano. Stress over newborn, new responsibilities, and changes in routine. Postpartum OCD can immediately be there after childbirth, definitely because that's when everything drops, and symptoms, disturbing thoughts and excessive behaviors that are regarding the baby. Pregnancy, respiratory at 2 weeks, postpartum 11.3, at 6 months, postpartum 10.6, higher percentage of women at 6 months postpartum with aggressive obsession. So let me talk about, we have 15 minutes left. At 6 months, they still have aggressive. They either have aggressive obsessions, I'm going to kill my child, with the knife, throw him out of the window, drop him on the floor, and all kinds of variations, or they have sexual. I'm molesting my child. I'm giving you examples of the most horrific images I've seen in my life, just to make a point. They are not all so horrific. Or sexual, or religious, and then she craves. But simultaneously, she may damage the child because she doesn't open the diapers, and she doesn't change him at all. She doesn't wash him at all. So he ends up being dirty. I mean, it's like, it's damage either way. It disturbs the family relationships, and Abramovich found this in 2007. Also, he found that a lot of men get OCD. And I talked before about most of the people, fathers get 80% OCD, not because of the hormonal changes, but because of especially if they're close to their wives, they get OCD because of their how close they are to the mothers and new responsibility. Not that they didn't give birth, but there is new responsibility, there is more to do, there are changes in the role, the mother loves the child now and they're upset and so on. Fear of contaminating the baby, and intentional harm, and recurrent thoughts of bad mothering. Increased checking, as I told you, this mother once and so checked all night the crib, whether or not the ones that crib died, whether or not he's breathing, not breathing, and then collapsed. I mean, the whole day, throughout the day, she couldn't take care of the baby. Mental compulsions, mental praying all day, and then the worst synonymous to compulsions is avoidance. In other words, no touching, not coming even close to me. Sexual aggressive obsessions, putting the knife to soft part of the hand, putting the baby, throwing the baby into the fireplace. It was shocking to me when I was treating this woman. I was like, how in the world do I create the exposure and responsibility? But we got the dog, the professional dog, and she had to hold the dog and put the knife to this baby, and I made hard days. And now we're sitting with the baby, holding the knife, and put her in front of the fireplace, and we have the gestures, which is throwing it over and over and over again into the fireplace. But it wasn't obviously big. So remember, compulsions can be hidden. They are overt or covert, right? Dr. Kroneman. Okay. Fathers, I talked about it, that about many fathers have that, and it was discovered recently, and it is not really related so much to the hormonal changes, but it is related to the stress. Risk factors in women. And once again, the reason, the whole goal of this lecture today, so kindly, and I'm so grateful. It's a great honor, Dr. Rapkin, that you gave me an opportunity to speak today, because my goal is to disseminate the knowledge all around, at least the United States, that these tests which are here and copied from white box that are given in gynecological offices and obstetrician offices, so that we can discover it very, very, very early, because diagnosis is the most important thing. So with cesarean sections and younger age of women, OCD can be triggered very, they're much more risk. Diagnosis during the pregnancy and postpartum needs to be diagnosed as soon as possible, and I have already talked about the reasons. Proper diagnosis and screening is crucial. Underdiagnosis and misdiagnosis. Underdiagnosis in general population is 7 years. Can you imagine cancer not being diagnosed for 7 years? Anyway. Or heart diseases, or diabetes, but what it is in cases of OCD. Every intern is screened for depression, for anxiety, for everything else but this disorder, because they're difficult to diagnose, because they also are very closely related to psychosis, and there is a lack of screening. And the patient thinks that the symptoms may appear to be too crazy to reveal, and that the patient will be thought of as crazy, and therefore they don't reveal. So asking 2 questions, just 2, would lead you to giving the whole package. Do you have unpleasant thoughts, urges, images that repeatedly enter your mind? Do you feel driven to perform certain behaviors as a result of the distress that these thoughts cause you? If the answer is yes, then please proceed. Ashley has made copies of the tests that and questionnaires that were provided to all of you to keep in the offices, so that the screening questions to be filled out during the exams for all women, and to have it uniform, because diagnosis is crucial. And UCLA has always been a pioneer in everything, everywhere. So therefore, it would be I would be very, very grateful to you if you took time to do that. And there is only one test that I have given you out of all these tests. There is also depression scale, also stage trait anxiety, and while yellow-brown scale for OCD I haven't given to you, it has to be properly trained in that to be done. Most of them are, but this one is easy to administer. It's self-administered test. Let's talk a little bit about other psychiatric disorders. There is postpartum anxiety. It's 13 to 40%. That is the reason onset. Postpartum depression, everyone knows, 20%. Postpartum psychosis, where is 1%, and differential is very, very crucial. It's similar. And please don't make a mistake there, because it's a world of the difference. There was a woman one endocrinologist was telling me a story of how she calls him. He was a friend of the family, and said, Dr. Dio, I'm boiling a casserole of water and my little Johnny, I'm going to make soup tonight, so please come over to have soup. I'm going to boil Johnny. And he had an office very close to their house. They were friends. Her parents were friends. And he said, I beg you, please just wait for me. I'll be there, my darling, very, very soon. And just don't boil him. Yeah. So he ended up, he said to me, Ida, it's unbelievable. I had like sweat. I was like completely wet by the time I arrived. Obviously the water didn't boil, the casserole was huge. And I said, sweetheart, just give me Johnny for a second. And she did. And he said, so 20 years later when I'm sitting at the dinner table, I always wonder, should I tell the little Johnny that his mother 20 years ago wanted to boil him, but of course he never did. But that's 1%. And also Child Protective Services are reported too. And I've talked to the mothers in great tragedy and told the stories to my husband, who is an attorney, about 15, 20 years ago, who called me out of state and their children were taken away by the court. Because they thought that it wasn't the fear of killing the baby, but rather it was intent, fear versus intent, and the babies, when they're taken, there is no way of getting them back. He told me, because I was literally crying. I said, do something. He said, there is nothing to do at this point. So this is, but it's only 1%, but still very important. Intent versus fear. Okay? And we encounter these cases because often they're afraid to kill themselves or they are intending to kill themselves. Okay. Now, postpartum post-traumatic stress in 5%, and postpartum eating disorders in 5%. Differential diagnosis, I talked about it a lot, worries. Am I good enough mother? Should I change the pediatrician? And OCD is obsession. And obsession is bizarre, inappropriate, intrusive, causes significant level of distress. And there are rituals, and there are compulsions. Because in any other disorder, there is no compulsions whatsoever. In Tourette's, it's involuntary behaviors. It is also neurological, and it's a cousin of OCD, so we know both illnesses are neurological. Postpartum depression overall, over time, is 57% of women. In depression, differential diagnosis is what? Mood congruent ruminations. Ruminations meaning, oh, I am depressed, I don't have energy, no stamina, I cannot do this and that. It's like mood congruent. Although OCD and clinical depression together are comorbid, and OCD is comorbid with many other disorders. And Dr. Sajid and I often talked about OCD being a syndrome versus an illness. Psychosis, I already was ahead of myself. It's serious, very serious. Luckily, it's not too much, but still this 1% can make a humongous difference. It's always assessing, and diagnosis. That is the most important. Postpartum psychosis occurs, but only in 1%. 2 weeks. Let's move on because I want to talk about the treatment. Assessment, psychoeducation, medication. Let's stop here for 1 second. 1 second, the medication long-term effects are not known. for pregnant women may be dangerous. We don't know. So and it works only 40% of the 50% of the people to 40%, and ERP works in 70% of the cases, ameliorating 75% of the symptomatology that lasts up to 6 years. The goal is to disconnect what? Feelings from function. Function despite the feelings. And now I can thank enough Dr. Rapkin for inviting me here, and I'm eternally grateful to Dr. Rapkin for diagnosing me properly, timely, and keeping me alive. I thank you very much. Any questions?
It's so interesting. So, if you see a person who meets the criteria of, I call you and I think I'm worried about someone who's 4 weeks postpartum with OCD, what do you think with effective modalities is the time frame where you see some improvement? The family then says, okay,
It can
what's
go
going
up
on?
to 6 months, and the data shows that it's going beyond 6 months. The intervention has to be find appropriate ERP expert who can treat the mother and the family, do psychoeducation, and do the ERP treatment.
But when you start, so let's say you start, not a psychiatrist, but you start there for 100 milligrams of Prozac or whatever.
Well, I don't know what to start with, but I just said that we don't, if she is feeding the baby, breastfeeding, I just don't know. Dr. Sajay is here, biggest expert at UCLA on medication. Yeah, I only trust you.
About that. But look, in order to get a response from medications, you're going to wait with an antidepressant 8, 10, 12 weeks. ERP, and you can speak to this better, ERP, you would start to see within what? Week, 2 weeks, you can begin to
With
see
ERP,
changes.
you see if they do what you tell them to do. Now there is different here. It takes a lot of effort on the part of the patient to do ERP. It's very hard work, extremely hard work, and dedication. But you can see results within and we change. There are our studies from UCLA show that we change the brain with ERP within 3-4 weeks.
Okay, so that part, so it's just time.
But medication, long-term effects we don't know, and their effects on the breastfeeding mother we also don't know. So what I'm saying, basically, I just said that that medication will take up to 12 months at the highest doses to have an effect. In 50% of the cases, they respond. Otherwise, it's trial and error. Of course, when not a pregnant woman comes into our office, we do both. We always do both because it's not a trial. It's not so. But the empirical studies show that exposure and response prevention works the best. Did I answer the question?
Yeah.
Yeah. Okay. Yes.
Wonderful, thank you.
Do these patients need to be hospitalized, and when they come to your institute, do they come every day? Do they stay?
They come every day.
So
We check on them in the evening, if necessary at night. I mean, it's like we do this. This is an intensive program, and most of them are not functional. And actually, we don't take ever more than 3 patients. Sometimes I will refuse even after 1 patient to take more because some of them are like, one is like 10, but you can take 2 definitely. And we involve the multidisciplinary team.
in the case that we presently have, we're gonna definitely involve also endocrinologists. But neurologists are already working.
Thank you very much.